The patient experience is pretty terrible. You have to know how to navigate it. And even as an industry insider, sometimes it is extremely difficult. And is it the payer's fault? No. Is it the provider's fault? No. Is it pharma's fault? No. It's everybody's. So how do we do better?
Hey, it's Nick and Mitch, and this is Provider Data Dorks. We're joined by Eric Galvin, former president and CEO of ConnectiCare, now advising through his own firm, Yarmouth Ventures, talking about broken directories, why nobody competes on a doctor's address, and the data healthcare never collects about you.
The real problem in healthcare isn't so much the administrative expense spending. Yes, it can be managed
Never
better.
hurts to bring it down.
Never hurts. But at the end of the day, it's the unrelenting trend that continues year over year over year of medical cost spending. That 8% would be helpful in 1 year, but it really doesn't solve the cost problem, nor does it solve the trajectory of our spending.
Walk us through how well-intentioned incentive design can end up degrading an experience that maybe it's intended to improve.
Using the STARS methodology as a prime example, all of those measures are all well-intended, right? But if you think about it on a patient basis,
Welcome to the Provider Data Dorks. I'm Nick Helfrich.
And I'm Mitch Gorodokin. We started this podcast because one of healthcare's most important problems is also one of its most complex, provider data.
Provider data is the invisible backbone of healthcare. Providers don't get to see members and don't get paid for those services without it. And members can't find doctors and physicians they need without provider data.
And yet, Nick, every health plan or healthcare organization that we talk to is still working out of manual spreadsheets or siloed databases or disparate systems, and none of them even talk to each other.
I know. Each episode, we want to talk to the leaders trying to fix provider data. We're talking about the individuals that understand where the problems are, where the skeletons are buried, and how to fix it.
You're going to leave this episode with a deeper understanding of what's at stake, truly what the problem means to the industry, but most important, what our leaders are doing to solve it.
This episode, we're joined by Eric Galvin. Eric, thanks for joining us.
yeah, thrilled to be here.
You've had an illustrative career that I think anybody should be proud of, but you've been in the healthcare space for 30 years. We were joking before we got started. I think we've all kind of accidentally pegged ourselves as healthcare guys, but maybe we'll get into some of your future experiences here towards the end of this. Your payer career includes leadership roles across several of the country's most prominent regional and national health plans, ones that Mitch and I would beg to work with, I think. You spent 8 years at Cigna in finance and underwriting leadership roles early in your career, transitioned to Blue Cross Blue Shield of South Carolina, where you spent 18 months. I'll get the pronunciation wrong, and Mitch will butcher me for it, but Geisinger Health Plan is where you most recently were, and we'll come back there. You're with ConnectiCare, where you joined the organization as the chief financial officer before becoming the president and CEO, ultimately spending more than 9 years with the health plan. You led ConnectiCare as president and CEO from 2017 to 2022, and then spent time at EmblemHealth while leading ConnectiCare, which is an EmblemHealth subsidiary. You also served as executive vice president and chief growth and medical cost officer for the broader EmblemHealth organization. You served as CEO of PopHealthCare and Emcara Health, where you led national value-based medical group focused on bringing advanced, primary, and complex care directly into patients' homes, which ironically was acquired by another one of our guests, Vasar Tassimi, which the audience will be familiar with either in the future or has already listened to that podcast. And then most recently, we're with Geisinger, which is where we started. So that's it.
Yeah, I
Just a couple things.
it's been boring. It's been very exciting. No, it's been great. It's been a great journey, and I've been very fortunate to get to see a lot of different things.
Yeah, I think one through line that we talked about early in the conversations is you've described yourself as someone that's not scared of a really big bet. And I think you believe that if you're striving for excellence, those hard challenges that you're going to run into while you're striving for excellence are worth the risk, worth the sacrifice, because the opportunities can be really fantastic at the end of the day. And you don't get the opportunity without the risk. You're always swinging for the fences, and for better or worse, because when you take challenges, you were going to run into those pieces. Talk us through your career journey through that lens.
Well, it really started well before I got into the working world. And one of my earliest influences was my father and my uncle being in business together and watching the success and failure, right? The seesawing back and forth. And watching that and thinking, is it really that hard? So that was a real early influence. It's what got me into business. Accounting was my chosen technical skill, and I view that as sort of the language of business. But when I got into the working world, it was really around how do I get as much exposure to all of the different stakeholders so that when I have an opportunity, hopefully at that time, to run a business, that I've gotten a chance to see that business through those stakeholders' eyes. And so early on, I had great mentors throughout my career, still do. And they really encouraged me to take on hard assignments. Don't take the softball ones, and do that as you're trying to accumulate all these different experiences. So that's been the playbook, if you will, to my career. But then there's been a lot of, failure along the way that I've been able to learn from.
It's a great place for us to start. You have such an illustrative career from the payer side, the provider side, now as an advisor and a consultant. As you think back on your career, what are some of the things that you didn't notice when you were deep in it with one single organization? If you can zoom out now, what are some of the lessons that you've learned across those different experiences?
Yeah, one of those is looking at how incentive alignment really influences behavior. And I'll never forget there's one project that I was on at Cigna, and I was a zealot about it. It was like, how does this not make sense to everybody in the room, right? Like, doesn't this just make sense? And what I didn't consider is that there were other incentives or disincentives for people around the table that didn't positively influence their behavior, right?
Yeah.
It didn't align with what I was given as an assignment. And then when you zoom out even further outside of the payer organization, providers were involved in that as well. And there was no incentive for them. In fact, there was a very large disincentive for them to participate. So really understanding, sort of that playing field and appreciating that you have to bring others along and try to get the right incentives aligned. Otherwise, you're going to have, at best, a partial success.
Yeah, I mean, you mentioned to us a line that I would love to put on a poster, which is when incentives are aligned, you get the behavior that you intend for, good or bad.
Right.
Right now, those incentives are pointing towards star ratings, quality metrics, value-based contract measures, and they deliver documentation and gap closing, but not necessarily listening to the patient or thinking about outcomes. Walk us through how well-intentioned incentive design can end up degrading an experience that maybe it's intended to improve. I think we're seeing that right now with some of the regulatory changes in provider data and really designing incentives towards compliance, but not necessarily care outcomes.
Without a doubt. I mean, using the STARS methodology as a prime example, all of those measures are all well-intended, right? Age-appropriate screenings, mammogram, colonoscopy, they're all really well-intended. But when you think about all of the infrastructure that's created to manage making sure that people are getting that screening, it's done more at an aggregate level, right? What percentage of people are getting that screening or not getting the screening? But if you think about it on a patient basis, we just want them to get the care they need, right? At the end of the day, we're trying to, in that case, we're trying to early detect maybe something a lot more serious. And so that incentive, when it comes down to how many times did we call that patient or send a piece of mail to them, or from a provider perspective, we've prompted them in the EMR, make sure you get this measure and that measure, or this documentation, that documentation. We've talked about, you see the top of the doctor's head as they're charting, rather than this is why this screening is so important, and this is why we've been chasing you for days, weeks, months to get that screening. So well-intended, but the patient experience may be accepted or received very differently depending upon how much we've badgered that individual.
Yeah. I mean, I remember going to my annual wellness visit with my provider, which as a good citizen of the healthcare ecosystem, I went without a provider for like a decade. And I was like, well, I should probably do this.
Right.
And I remember going in there and he was clearly, asking me all the compliance-driven questions that he had to ask. And in this instance, I wasn't even looking at his head. I was looking at his back and he was turned away. And then it was kind of like he remembered like, oh, I need bedside manner. And he like turned around and like asked me some like awkward questions or told me a story about his family, which is great, his family. But it was just like a very interesting experience. You spent a lot of time within health plans. You've had a lot of success. You've taken big bets. I think part of your success was the ability to storytell and align incentives, which you'd briefly talked about. How do you feel about some of the projects or work that you had to do that was maybe government compliance driven versus like, here's the big bet we want to take because we believe it's right for the patient? And I think that'll lead to kind of another thought and through line of questions here.
Yeah, it's unfortunate, but sometimes necessary that you have compliance-related, objectives. And, frankly, I think an industry left onto its own can sometimes get itself off track. And I think healthcare is a great example of that, where the insurance side of healthcare, dating back to early 1900s, it was a good thing. It was economic security for people. And what that turned into was this enormous industry that regulatory bodies stepped in and said, well, here's this safeguard, that safeguard. And those, by and large, were put in place because they wanted to protect the consumer. And so I think the more ethically you can operate your business, the more patient-focused and customer-focused you can operate your business, whatever it is, whether you're a provider, whether you're a payer, or some other stitch of the ecosystem, the less regulatory intervention will be required. And so I'm a very big believer of free markets, but I do think that at times, those guardrails are necessary. And as a result, you have to invest in those efforts, those projects that are purely compliance oriented.
Well, and I think this is what keeps payer and provider executives up at night. Like history shows us, and you kind of just walk through that if we don't do a good job as an ecosystem, the government's going to step in with some 3-letter acronym, whether it's CMS, JCO, URAC, or something else, which only one of those was 3 letters. But you guys get the gist. They're going to step in and they're going to tell us what we have to do. As a capitalist that believes innovation comes from the private sector, and I believe the same thing, which is why I'm in the private sector, what does the industry have to prove, and like, how long do we have?
Well, I think we've already seen this happen, right? The Affordable Care Act is a great example of that. I think we're feeling the negative effects of that right now because healthcare coverage is not terribly affordable. Frankly, I'd say it's not affordable for
It's
most.
like the top topic this year. I remember being at JPM and there's like affordability,
Exactly.
cost of care everywhere.
Exactly. And is it the payer's fault? No. Is it the provider's fault? No. Is it pharma's fault? No. It's everybody's, right? And so, how much time do we have? I think we're past time. And the dominoes, I think, are all set up right now for another massive change in the industry. And if not, then the everyday person is going to be the one that suffers because more and more of their pocketbook is going to, or their wallet is going to be hit with costs. We just haven't done a good job as an ecosystem. We've tried a lot of things, right? Value-based reimbursements, patient-centered home, all of those things have been very well thought out. But have they fully achieved the goals? I would say probably not. So we're just not there yet.
Yeah, I mean, I think we hear about it a lot in our line of work in terms of administrative waste and administrative spending, particularly around things like managing provider data, inaccurate directories, rejected claims that are happening as a result of bad provider data. And even if you stripped 8% of all administrative spending out of the equation, healthcare still wouldn't be affordable or sustainable. So if admin efficiency alone can't really save us, where do we go from here? Where should we be spending our time and energy?
Yeah, and just to put that 8% into context, in the payer world, 8% administrative expense ratio is pretty darn good, right? I mean, you're doing well if that's the case. That assumes that you're spending, let's just call it, 90% on patient care or 85% on patient care. So if you took all of that administrative expense, all of those salaries, all of that out, for people who, for instance, are single payer advocates, right?
Yeah.
That 8% would be helpful in 1 year. But it really doesn't solve the cost problem, nor does it solve the trajectory of our spending.
Can I play that back? Because it kind of snuck in. It's like that the 18%, or if you think about a medical loss ratio of 15%, if you move to a single payer system, in theory, that would go away, right?
In theory, it goes away.
But it really doesn't have that big of an impact if it does.
Well, the government would have to step up with, either more employees or, you think about Medicare Advantage, putting it out to private organizations who are going to want some return on capital and the risk that they're taking. So it doesn't go away.
Yeah.
But the real problem in healthcare isn't so much the administrative expense spending. Yes, it could be managed
Never
better.
hurts to bring it down.
Never hurts. Never hurts. But at the end of the day, it's the unrelenting trend that continues year over year over year of medical cost spending. And again, it's not any one organization's fault. It is the ecosystem not doing a good job of keeping healthy people healthy and out of, big expensive facilities, and those who are ill doing the very best that we can in managing their outcome and their health, but also the cost.
Yeah. There's this, it's this combination of I feel like it's this combination of not truly getting to whole person healthcare, where we're bringing in people's medical conditions with their mental health care conditions.
Absolutely.
And their environment, their socioeconomic status. It's GLP-1s flooding into the market. There's so many of these different things that are outside of the ecosystem.
And by the way, that GLP-1 is as an example. What an amazing technology, right?
Yeah, it's
unbelievable. And if that has knock-on effects 5 and 10 years down the road for somebody that, lost a bunch of weight and now is a little bit healthier and so on, great. Does it need to be as expensive? Or you think about other industries, right? Think about electronics. Flat screen TVs were extremely expensive when they came out. And now, you can buy them very inexpensively.
Yeah.
Healthcare doesn't seem to work that way. Some things come down in cost. I used to use the example of penicillin, right? You look at the cost of penicillin. This is a technology that's been,
Accidentally discovered.
right?
Like 50 years ago or something, right?
More, like 100 years ago. And here we are. It's more expensive today than ever. So again, there are these economic dynamics that don't make sense when you think about it in context of other industries.
Yeah.
So how do we do better?
I mean, I think right now there have been a lot of efforts to try to bring spending down, right? So we've got right now turmoil around the ACA or Medicare for All or, Medicaid funding turmoil. And it just doesn't, and, you have camps on both sides of the fence here. It's not like people aren't trying. It's not like people aren't voicing, their opinions at the government level as to what we should be doing. Right now in particular seems like a really crucial tipping point, and it seems like we're about to head into another cycle of what's next. So talk about why you think maybe it's so important right now, why right now is such a huge, crucial point.
Well, one is the affordability conversation that we just had, but then there's the patient's experience that, as much as doctors' offices or other types of clinicians or some of the other players in the ecosystem, they're, again, well-intended, but the patient experience is pretty terrible, right?
Yeah.
It's sort of, you have to know how to navigate it. And even as an industry insider, sometimes it is extremely difficult. A colleague of mine, this is going back a year and a half, she found out very early that she had a breast cancer diagnosis. This is a person that has spent her entire career in healthcare, more on the insurance side. Listening to the challenge that she had, getting specialist appointments timely, and she's a tenacious person. It was such a struggle for her. And if she hadn't been as hard an advocate for herself, she would have had that course of treatment for many months longer than what she ended up living through. And, not only the physical impacts, but the mental impacts of what that did to her. It was a lot. And so watching her go through that, that was a real eye-opener for me to say that, even industry people have a hard time navigating when they truly need care. So I think, to get back to your question, I think now, because the economics are so broken, but equally that the patient experience is a real challenge, particularly when you have a serious health event, I think now is a bit of a watershed moment.
On that watershed moment, I think we had another watershed moment with COVID where we now have this, you have talent and access to healthcare has gotten far more portable and just your ability to access that care. I don't know that the administrative machinery has caught up exactly, but providers are moving faster than the systems that license, credential, and enroll them. You can now, your coworker that had breast cancer, there was not that long ago, you'd have to go into the clinic, you'd have to work the phones, you'd have to send mail, you'd have, medical records and 6 different medical record charts, you'd have your inpatient, your outpatient, all those pieces. That's more accessible at a central location now, and that's made it a little bit easier, but we have to make sure that we're keeping up and making sure the providers can access these pieces. Paint the picture for us. What does the disconnect look like on the ground on like how portable providers are versus that administrative ecosystem that gets providers to the members and patients that need that care?
Well, you live it every day, right? You think about the provider data from the perspective that it's an identification number, it's a name, but it's also an address, right? And sometimes as claims come in the door administratively in a payer, if those don't all line up, then that claim doesn't necessarily get paid, or it gets an incorrect reimbursement amount assigned to it. And that, my gosh, you think about what the industry spends and the bad blood between provider organizations and payers because, this box of claims wasn't paid correctly. So the portability of the talent being, potentially not having an address, right? They're mobile. They're going to go to where the patient is. I think the administrative processes have not, as you've said, caught up with a new dimension that we're operating in. And that's incumbent upon us all to do that, right? And to change the systems and adapt. The other element, thinking about that, it's the only industry that I know of that when a bill gets sent out, it's sent out without the amount that they expect to get paid, right? And it's like this game back and forth, like, are you going to get it right? Well, we think we're right. And again, we spend so much, talking about that 8% of administrative expense, we spend so much resource, time, money, frustration in a lot of cases, trying to get that right. It's such a massive opportunity. And I think provider data, to your opening point, it's absolutely the backbone.
Yeah.
I mean, we talk to so many groups and they all seem to agree on the ground that we do not compete on the basis of provider data. A rising tide in provider in sharing resources and being collaborative in this space should lift all boats. And yet, it's still so difficult for folks to collaborate within the payer space, payers against providers. And I even hate saying that, payers against providers. We should be working collaboratively. But why do you think that in healthcare, it is so tough to have that more traditional business or partnership relationship?
I think it really comes down to trust. I hate to say it, but I think that there has just been so much, I'm going to find a way to maximize my output typically in economic terms, at the cost of you or you or you. And so when there is something that is well-intended, then, there's trepidation that, are they really trying to do something to get a hand up on us? I mean, provider data really at the end of the day, maybe the tools that use them are a differentiator, but the data itself's not a differentiator. You would think it...
A provider's address is not a surprise.
Right?
It's not different at Cigna versus
it shouldn't be, right? And that
shouldn't be a surprise.
And there are industry groups that you would think would want to take advantage of their membership, right? AMA, the ADA, right? All of these organizations that have a membership base and monetize the fact that, they have a mailing list, right? Or why couldn't we have 2 or 3, think about credit reporting. Why couldn't we have 2 or 3 organizations in the provider data space that if you're a provider and you want to get paid correctly and quickly, I'm going to make sure that all of my information in there is correct. And if you payer aren't drawing from that, well, shame on you, right? Because you're going to be swimming upstream trying to keep all of that data accurate yourself. Again, I just think that that's such a solvable problem.
Yeah. Earlier in this, we talked about the private sector trying to address the problem versus CMS or whatever governing body might do that. On topics like the one you just walked through 10 seconds ago, like you've got the Real Health Providers Act, which is going to try to push some of that and put some accountability both on health plans, which will now get scored on their directory and it'll be public facing, and then the providers and the onus to make sure that they are attesting that these addresses are accurate on a regular basis. We'll see what happens. It's not till 2028 and it's just Medicare Advantage. There's some promise there, but how do we as like the private sector continue to push this and centralize more and more of it on our own? And when we talk to plans, there's a big drive to do that. Like they would much rather do it on their own and help members get access to care as fast as they can. Like that always holds true in our discussions with plans is they do want a really strong provider experience and they do want members to access care with those providers. So I don't think either is necessarily the bad guy. I think there's some natural friction in business, especially, not that payments are a zero-sum game. There's that natural friction we'll run into, but the positivity and the desire to do good is definitely still there.
And I think you all are innovating with some large payers right now to collaborate together, right? That's a huge step forward. Now it's, can we get our provider partners in the under the tent as well? That would be a massive step forward.
And the theme of a lot of our collaboration with payers has been we, the payers, want a better provider experience. We don't think a provider should have to go to, I think about like Summit County, Ohio, which at least a couple of years ago was like the most competitive county in the United States for Medicare Advantage health plans. There were like 17 plans. So if you're a provider in Summit County, Ohio, you got to go to 17 different health plans and work through 17 processes. That's terrible. Like if I had...
Absolutely.
So, and the payers do want to centralize more of that for the provider, because at the end of the day, providers want to provide the care and health plans want to provide programs that lead to better member outcomes.
It's one of the things that's led to all of the primary care and some specialty care consolidation, right?
Yeah.
So they just can't keep up with all of the demands of these different payers and government regulation, as we were talking about before. And it's unfortunate because when you become a part of these big delivery systems, there are expectations around productivity and so not that there wouldn't be if you remained independent, but you're your own practice and you can manage it as you see fit.
What is it? RVUs?
RVUs, yeah.
What is RV? I can't. Do you know what that stands for?
Revenue value unit, I think.
Yeah. So it's like you get part of a big idea and then you've got these revenue value units you now have to contribute to. We heard an interesting lens on large health system networks earlier this week too, is they have these large networks. They negotiate contracts with the payer as a delegated entity. And sometimes it's a subset of the specialists that matter the most from like a network adequacy lens in St. Louis. And then everybody else just becomes a big part of that because you need XYZ specialties for network adequacy. It's interesting. It changes the negotiation strategy, I think, in big ways.
Yeah, and that's where, the birth of narrow networks came from. And then the narrow networks had to meet adequacy standards. So now who else are you going to add? And how does that change the pricing, right? Because the whole theory of the narrow network was best quality and lowest cost, or at the best possible cost. And then you start adding people back in and adding practices back in. And sometimes that dilutes either that great quality or that, that reasonable cost.
Yeah, when we think about, these shared services and collaboration across the industry, what we're really focused on and what we talk about a lot with our guests is that the concept of laying an infrastructure that a lot of folks can plug into and really increasing that goal of interoperability. Epic is one of those examples of maybe a promise of interoperability where even when everyone is on Epic, they still have their own flavor and data does not necessarily flow as freely as maybe it was promised to flow. What's the honest scorecard on that generation of investment of interoperability? What can we learn, or what does that teach us about that next generation of provider data interoperability?
EMRs are a great example of where there was such promise that EMRs are going to make documentation easy. That data is going to travel with that patient, et cetera, et cetera.
I'm a recovering EMR salesperson. So
exactly.
If I start jittering here, I'm sorry.
No, I'm sure there's an element of PTSD there. But not to discount what the EMR has done. Right now, I can take my phone out and look at my lab scores from, my last physical. Okay, that's wonderful, and that's a great step forward. But it's sort of trapped in that EMR. It doesn't really travel with me, and that I think that's one of the learnings for me coming out of seeing it from both a payer and a provider side is that an asset of the patient, or is that even though it's their data, it's really being housed with the provider. And there are so many of the providers in the ecosystem that are outside of the Epic world. And some of those values get in there and some of them don't. The large labs, they've all done a great job of interoperability of that data. But think about mental health providers, right? Which is starting to get consolidated, but is very disparate versus, traditional.
Still a lot of ones and two doc practices.
Lots. And that's not the strong suit, right? That's not what they got into, nor are they reimbursed at a level that, allows for a lot of investment in infrastructure. So there is so much data that is really relevant that isn't there. Dental data, right?
Yeah.
We talk about whole person health. There's still a lot and a long, long way to go on both interoperability of data that sits outside of Epic, in addition to where's my thumb drive, or where is that data that I can go to another provider and say, here's everything you need to know about me.
And if I were to look at the other side of that, and we've talked about this before, it's on the provider data, taking a provider data lens from it. I mean, providers should be owning and managing their data, and they should say, hey, this is my data set. And as I go from provider system to provider system, or from plan to plan, here's my data set. And they own their data, they control their data. And it should be a lot easier to be able to port that over from one group that they're working at to the next, particularly when you're thinking about maybe behavioral health providers who practice under 5 different groups and, are in network with 12 different health plans.
Right.
And that data is consistently changing. And instead of maybe throwing it over the fence to the plans to be responsible for validating and managing their data, which some of the regulations, Nick, that you mentioned are focused on, maybe we give the hands back to the provider, the data back to the provider.
Yeah, indeed. And make it easier for them to do it, right? I mean, ultimately, at the end of the day, I really think the provider experience is pretty terrible right now, right? I mean, they got into their line of work because they wanted to help people by and large. And I think they all had an expectation that there's some administrivia, but then you get like through the door, wow, right? Like, how much time am I spending with that patient, taking care of them versus, charting and following up on this script or that script that didn't go through to the pharmacy correctly. Whatever, we've just built a lot of this administrative burden in there, some of it necessary and some of it not. And it's a really terrible experience for the provider.
It's like we talked about my example going to a primary care provider.
Yeah.
He didn't want to have his back turned. Like, he didn't get into
not.
medicine to have his back turned and enter in a whole bunch of data. And Mitch said this at the very beginning. One of the things that he wants to put on a poster that you've said is when incentives are aligned, that's going to drive the results, good or bad.
Right.
And where we've seen incentives aligned lately is caps, quality metrics, stars.
Right.
We can continue to push some of those pieces. And you have a doctor that's focused on care gap closure instead of having that discussion with the patient of like, oh, you struggle with migraines. When does it happen?
Right.
How do you work through those pieces, and having a discussion? Walk us through how well-intentioned incentive designs can actually degrade the experience that it's really supposed to improve. Like, the incentive design is there for outcomes, but there's a big argument that maybe it's degrading some of these experiences.
Yeah, for sure. And the example that you just gave, I think, is a prime one, right? So, trying to close a gap in somebody's cholesterol level, or we talked about screenings a little bit earlier. And if that's the checklist versus what does that person do for hobbies that might create health risk, right? What else do they do in life that might create a problem for them either today or down the road? And if I think about the provider themselves, they want to take care of the person, but they're stuck in this transaction instead of a longitudinal relationship. Again, we as an industry have just made it difficult for them to think about that individual on a longitudinal basis. Like, where is this going to go for you if you continue to do this? Instead, it's, tick this box, write this value down, et cetera.
Are you familiar with and this is not something we've talked about in our narrative. Are you familiar with the Function Healths of the world?
Yeah, I'm familiar with Function.
Yeah. So Function Health, ironically, today they raised, I think, $450 million from General Catalyst, who's an investor with us. This is not a plug for them, but a $450 million investment, they're doing something right. And then you've got groups like Function Health that are saying, hey, you, Mitch, maybe you don't like the healthcare system today, pay us. It's usually a pretty large sum of money. I think it's in the thousands for a lot of those engagements. Right. But they're not worried about quality, stars, or anything else. They're worried about Mitch. They're worried about Eric. And people are getting drawn into those models because all of a sudden it's, hey, I as a provider want to provide care in that market because I'm focused on Eric's whole person health. And I as a patient want to get into that model because the provider is focused on me and that feels good and I'm seeing results. So it's interesting to see that juxtaposition, I think.
Without a doubt, and Function raising that amount of capital in this private equity environment today is amazing. There are a lot of parallels around the globe that if you look at markets like the Middle East, you look at UAE or in Asia, there's the public-private sort of split, right? People who get their healthcare from, or even in Europe, right? In the UK, you get the NHS coverage, which every UK citizen gets, and then if you can afford it, you'll subscribe to a private healthcare plan, and that's exactly what is evolving here. Is the administrivia, all of the burdens are becoming too great that if you pull that out, and if you have the means as an individual or a family, maybe it makes sense to spend. And this is why I was mentioning the watershed moment is we're starting to approach those dollar amounts of what an individual or a family would have to spend in order to access that type of concierge care.
Yeah, I mean, you were saying earlier, the providers and the payers are kind of bickering and going back and forth. And meanwhile, the patient, the member is sitting on the outside looking in like, where am I?
Right, exactly.
It's like, hey guys, I'm still over here.
Excuse me.
And
excuse me.
To your point, it's like we're reaching a point where maybe you'll put up with that up until a certain point for financial stability or peace of mind, understanding that God forbid you go through an experience, you're covered by insurance. But now we're reaching the point where actually maybe I wouldn't mind taking on myself, and that's why you see the Function Healths of the world doing some direct to consumer. I think we talk a lot on the show about this consumerization of healthcare, and when I go to a barbershop, for example, I have a pretty personal relationship with my barber. Right. When I go to, maybe not Nick, but
I am my barber.
But it's like there's a consumer driven approach that you can have when you have these personal relationships with people. And I think sometimes we lose that with our doctors, we lose that with our providers. Can you talk about maybe how provider data may start to enhance that experience and understanding your provider more? You talked about a story about, a patient coming in with a coffee to his provider and providing a coffee and getting a better experience there. And that's just the human element of that.
I try to always bring Sandy her favorite coffee from Dunkin' Donuts, and
Dunkin', you are a Northeastern guy.
Yeah, well, I mean, I am a Starbucks kind of a guy.
No free ads.
Yeah, I know. Sorry.
Starbucks, call us.
There is something to be said for that personal connection, and I do that. I bring that coffee more because I want her to know that I appreciate what she does for me. And I have a great relationship she's the medical assistant, and I have a great relationship with my provider. Where I think data can come into the picture is as much data about the provider. Certainly, I could get to know my providers better, like what's their favorite coffee, but then they could also get to know the patient better too. And we're missing a whole layer in the data ecosystem. We're missing a whole layer that is more consumer oriented data. So my eye doctor is a great example. He knows that one of my hobbies, one of my passions is racing sports cars. And so when I go to see him, he knows that peripheral vision is particularly important. So we do a couple of tests that ensure that I know if that's degrading or not. if he didn't know that about me, he probably wouldn't do that one more test. And by the way, I pay for that out of pocket. That's like, I know that is just something but it's a cost of having that hobby. So I think that there's a layer of information and insight about an individual on the provider side, on the patient side, that is still missing.
That's fascinating. I mean, how often do you go to a provider and they start asking you questions about your personal life? What do you like to do? Like, what are your hobbies? What are some of the tangential elements of your life that I should know about? I mean, I would like to go to that provider. Actually, no, my mom's an eye doctor, so sorry.
Yeah, no.
But I would like to go to a provider that cares about me in a way that's deeper than that. And that's a data point that we do not currently collect.
Right.
Nick, you asked a question yesterday, like, what is the most important or overlooked provider data point? We talked about specialty, we talked about location, but what are those deeper elements?
Well, think about it this way. If you're a big runner, if running is important for your physical fitness, your mental health, it's something that you do weekends and evenings, or wouldn't you want to know if your doctor's a runner too? Or maybe have the opportunity to select a doctor that's also a runner, so that when you do pull that hamstring or you do have an Achilles injury, that they can identify with that.
Yeah.
So it's not a must-have, but it's an enhancement. And think about the patient experience, but also the provider experience.
It's a great example, actually. You just triggered a memory inside me that I forgot that I had. Shout out Dr. Price, my podiatrist. When I was in high school, I used to play hockey, and I had orthotics. I had flat feet, and he used to tailor my orthotics just for my skates. And he's like, it's because he played hockey. Yeah. His kids played hockey, and he understood how tough it is to fit into a skate with, and he didn't want my feet to be hurting on flat skates. So, super interesting.
Yeah, those are human elements that we don't activate through our systems, our tools, our data. It would be nice to be able to do that. And consumerism has come so far, including in healthcare, but not far enough.
I want to keep pulling at this, because if we think about consumerism and getting you to the right providers that know you're a runner, or, Mitch's example, played hockey and had the same life experiences as you, there's a lot of really great data. And I wish I had some of the data points here, that if you go to a provider like you, just from a race, ethnicity, and language standpoint, you have better health outcomes.
Certainly.
And that's a great starting point. But how far do you think we are from like the type of care routing we're talking about, where it's like, Nick, you are a runner that has 3 kids in the St. Louis metropolitan area. This is a provider you're probably not thinking about, but you should consider that extra 10-minute drive, or you should go to this provider that is in your network. Now you have to worry about this concept of being in or out of network on some of these pieces. But how far do you think we are from like that kind of intelligent patient routing?
So I think some organizations are doing intelligent patient routing, not on that basis today. Yeah. Think about customer care centers, right? They have usually this room, and now it's virtualized. That's their command center.
Now it's a chatbot.
Right, exactly. But they have this command center that is trying to match incoming volume with the right skill, right? The right capability. Oh, there's a dental customer calling, and we need to get them to somebody who's skilled on the dental product.
Yeah.
Clinical organizations have started to do exactly the same thing, and many of them have been at it for years, having their own command center, trying to match patient demand to capacity that they have. We need to now take it to the next level, right? To say, okay, from a consumer standpoint, what are the best matches? How do we get Mitch to that right podiatrist, right? And we're not going to do that in an environment where the economics are so strained that we're worried more about, Mitch, are you getting all of your, screenings right? Did you have a physical? Where's your cholesterol, et cetera? If those things aren't simplified, then we'll never get to that level.
I do wonder where PHI comes into play here, because when I go online, I get targeted with things that are so deeply personal, and I think it bothers some people. I think it bothers some people to talk about.
I needed these Lululemon shorts,
but I love Lululemon. I do need some Lululemon shorts, Yeah. And so I think some folks are bothered by it. I personally think that it's great to be recommended something that I absolutely need, and like to your question from earlier, Nick. how far away are we from this? I mean, the technology exists
Absolutely.
to know that I play hockey. The technology exists
Yeah.
to be able to tell my podiatrist, hey, be on the lookout for this. And on the flip side of it, I should be able to know that these providers have that kind of experience and have
Right.
that kind of thought process. And yet my PHI is extremely protected, and for good reason. But also, I wonder if we, again, from a regulatory standpoint, from a security standpoint, sometimes inhibit some of this whole patient care that you're talking about.
Yeah, I think we do. I think we do. The PHI, I don't personally mind if, some marketing organization knows about, I don't know, some health aspect
Yeah.
of me, but some people do. And they should be able to say yes or no, share this data, don't share this data. But Lululemon or, pick a company.
Whatever, D2C marketing, yeah.
Exactly. There's so much intelligence that already exists to match propensity to do something, in this case, buy a pair of shorts, to that individual. Yet we're not taking advantage of that, or not fully taking advantage of that in the healthcare space.
I almost feel like this is like, and I was at Cerner for almost a decade, and we were talking about population health, and this was 10 years ago. And we've been talking about population health for 20 years, if not longer. And I almost feel like what we're talking about was kind of like the promise of population health,
Yeah.
and what it's turned into in reality. And this is like a glass half empty view of it. But what it feels like it's turned into is like population health is your network adequacy. And are you in a healthcare desert, or do you have access to a lot of deserts? And here's your heat map that shows that.
Right. So population health is one of the terms that I despise the most
Oh,
in the kind of ecosystem.
I can understand why.
Yeah, and it's more maybe a PTSD moment where when I joined a particular payer, a lot of focus on, we take care of the whole person, and we don't have individual programs for high blood pressure or whatever.
Yeah.
And yet, at the end of the day, the blocking and tackling of when you're looking at Eric or Mitch, or you're looking at patient information. What do you do? And I think population health just sort of glommed it all together, and we got out of practice with how do you treat that? How do you take care of that? But even more, I think, fundamental is, what are all of the things that keep people from getting sick to begin with? Or if there's a family history of hypertension or heart disease, like, what can they do? And are they staying focused on those activities, or are they sliding down a bad path? So again, getting back to data, it's putting that in front of the doctor. It's linking that to an individual. It's trying to use some of those consumer-like prompts to say, put down the donut and grab those Lululemon shorts and,
Go for a run.
Exactly.
Seriously, it's fitness has a ton of benefits. So population health, I agree with you. I feel like it's like a fat political word. Like, I think that you see a lot of those.
Again, well-intended, right?
A well-intended,
poorly executed
political word. Yeah, poorly executed word that we'll be talking about for another 20 years. We'll get there later. It was one of the things you dealt with as an executive at a health plan. As an executive at any of the health plans across your experience, what was like your general view on provider data? Did you think about credentialing, contracting, network adequacy? Like, what was your interaction with the dorky space Mitch and I play in every single day?
Well, depended on the payer. In one instance, it depended on the organization. In one instance, our directory data was really, really bad.
Just one?
Well,
statistically, all of them.
Yeah,
No,
yeah. So this is on a relative basis, really, really bad. To a point where there were some regulators that were concerned that we didn't have the right data in place to help the consumer. Okay, so that, as you might imagine, got me like way down into the weeds of why is this a problem, and really trying to understand provider data at a much lower level. And then in another organization, and I'll stitch these together, I promise. In another organization,
and you're like, I don't want to be here.
well, it's a scary place, right? There's all kinds of scary reasons why the data is what it is, which we've done to ourselves as an industry. In another organization on the provider side, it was about how quickly can we get this individual credentialed so that we can add capacity for people who need to be seen.
Yeah.
And all of the reasons why that's difficult, and hence your existence as an organization, right? And things that we as a provider didn't do well specifically. So when I got to see both sides of that, or at least from two different points of view, I just think that there is natural complexity to the fact that in order to adjudicate a claim, to have a directory that's accurate, to get paid the right dollar amount, there are just certain basics that have to get done, and that takes time, and that takes resource, and why we do it all individually, thousands of times across this country is the silliest thing in my mind. I really think consolidation, a clearinghouse or multiple clearinghouses on that front should be doing a better job.
There are a lot of VPs of provider ops, directors of credentialing, directors of provider data management that are listening. And I think they maybe sometimes don't think that they have the executive air cover that perhaps they're looking for as they're trying to implement transformation into their organizations.
Sure.
As an executive who has gone into those weeds and has seen the dirty, scary truth down at the directory level or at the claims level that's impacted by provider data, what can you share with them about, how they may be able to work with executives to get the support they need?
One piece of advice I might give any of those individuals is don't be afraid to manage yourself out of a job, because that will be the ultimate success of your efforts, right? Is not needing somebody who is so experienced and skilled as they might be to play that role, that it becomes very much a background kind of process or activity. So number one, don't be afraid, and maybe even state that, my objective, and I tend to say this when I come into a role, is I want to manage myself out of a job. That's ultimate success. I can focus on other things for the organization, but so that would be one. The second, around gaining that air cover, is I think it's relatively easy to show the value of good, clean data. And yes, we'll always have exceptions. So there's going to have to be some degree of work and people putting their hands on keyboards. But telling that story, right, is like, here's the value, and here's why investment in it, not as a project, but as an ongoing, continuous improvement, strive for excellence, swing for the fences, right?
Yeah.
Get that infused in that team, in that organization, so that you manage yourself out of a job. I mean, that is and it probably sounds like it's so generalized that a VP who's listening right now of provider data, they're like, yeah, come, live a day in my life, but really focus on that continuous improvement so that you slim the organization down smaller and smaller and smaller.
Well, I think if you manage yourself out of a job, the next job presents itself, and it's a higher order task that drives more value than whatever the task is that you're focused on today. If we solve this problem, now we get to start talking to providers about the next conversation that's a little bit more strategic, a little bit more focused on the member. So
Completely.
I love that framing.
Yeah, wholly agree.
I have to read straight from the speaker notes. It almost made me read out loud. But the system we have is a spaghetti of Band-Aids, which sounds disgusting, but is what the sheet says, people. But it was built in the 70s, patched in the 80s, 90s, even today. You get to start from scratch. We don't have to worry about untangling it. It's a blank slate. What is it going to look like? What do you keep? What do you throw away? What do you completely reimagine, and where do you start?
The list is long.
Yes.
Top of that list is get rid of the build and allowed, get rid of all of that layer of, as we talked about a little bit earlier, I'm going to bill you something I'm not expecting to be, paid. So get rid of that. Send a bill for what you expect to get paid, period, full stop.
Yeah.
On the product side, simplify the products that we have. The insurance products have become so complicated because we, like the game Whack-A-Mole, we're trying to stamp down utilization or a unit cost or a new technology. Is it included? Is it not? Simplify the products. And again, if you're working together as an ecosystem, it's a little bit easier to do, right? I've said to provider partners when I was in the payer world, there's plenty of economic resource here. There's plenty of money here.
Yeah.
Let's just do a better job of putting it in the right places and getting it to the right behaviors and outcomes. And I think you could do that through product design. You could do that through contracting. I mean, if you've ever read a provider contract, it just like your head wants to explode. It's so complicated, and all of the positioning and all of the administrivia that wraps around trying to administer those, and none of us get it right. Like literally, none of us get it 100% right on either end. So that simplification of product, of interaction between one another, of I want you to use my lab instead of, what's convenient for the patient, which happens to be like on their block here in New York City, right? We have overcomplicated this entire world. And that's why it is so expensive.
So that makes sense in terms of starting from scratch and from a clean slate. But unfortunately, we don't have a clean slate. We're dealing with the same legacy vendors, the same incentive structures, the same systems. If you were a health plan or a health system executive today and you were dealt this, what was it, Nick? Spaghetti ball of Band-Aids.
Right.
Yummy.
What's one move that you would tell them to make this year?
I would stick with that simplify, right? I think there's a lot we could do without completely upending the industry by just simplifying, right? Let's just admit that we all are contributing to complexity. It's creating a lot of anxiety for a patient, for a provider. We're constantly trying to sort of catch each other in doing something wrong, or it's just not additive to the world, right? It's not in the best interest of what the objectives are. So you can still be a very economically healthy organization. You can still pay your people well. But I think that there's such an opportunity to improve overall and ultimately deliver a better product to that individual, that patient.
I love it. I mean, it's something my grandpa used to always tell me, kiss it, keep it simple,
keep it simple. Yeah,
and
without a doubt.
I think there's something to be said for that.
And even on the regulatory side. So I didn't say that with a clean sheet,
Yeah.
On the regulatory side as well. Like let's rewind some of these really onerous regulations.
Yeah. Let's jump into the lightning round a little bit. A couple quick questions. I have a fun one off script, but you mentioned one of your hobbies is driving sports cars. Right. What's your favorite sports car you've ever driven? Oh gosh, it sounds so out of touch of me to even say. I'm a very, very big Porsche fan, so there's so many of their vehicles that are amazing. So I'll go with that. But feel very real when you're driving them. I
just
imagine
visceral, right?
Yeah.
It's just such a passion of mine. It's always been since I was a teen. So I'll go with that.
Passion. We've gotten so much great advice from you today. But what's the best or worst advice you've ever gotten?
I would say best advice is embrace failure. You have to embrace failure because it's going to happen. And especially in this line of work, it's going to happen. And it's what you do with that failure.
I've one piece of advice that I got that I always like to stick with is get comfortable with being uncomfortable.
Yeah.
Right.
I like that one.
You got to live in the uncomfortable life.
To go from embracing failure and getting uncomfortable to asking you what's on your nightstand feels like a big drop in quality, but I'm curious.
Yeah. So right now I'm trying to get through a book. I'm not doing a very good job of it. It's called The Formula, and it's about Formula One as a sport and how it has evolved, not only as a sport, but as a global business. So, it's another passion of mine. And this book is a pretty well-written sort of insight into how it's evolved over the past 50, 60 years.
Do you have a favorite driver?
I do. It's any driver in the red cars. So I'm a Ferrari fan.
Porsche and Ferrari. Nice.
Yeah.
I have actually on my nightstand, coincidentally, I have a biography of Ayrton Senna.
Do you?
Yeah. I love him.
What an amazing figure.
Yeah. He's been great. He's done a lot of great things for Brazil, and his foundation is still doing a lot of great things for the kids
Still
there.
To this day. Yeah.
One wish for healthcare as we send our audience off.
Yeah. Oh my gosh. If I had to boil it down to one, I guess it would be, stop fighting one another as much much like let's give each other a reason to trust and do good, responsible business with one another, with the patient at the absolute center of everything that we do.
And I think that's a theme that ran true for the last hour that we've been able to talk is like, let's create a simple system that focuses on the patient at the end of the day, whether that's been you as an executive coming in and looking at provider data or working through compliance-ridden healthcare ecosystems that we've created. It's all about how do we make something simple so that we can all get great access to care, our families can, and the people we serve can.
Without a doubt.
It's been a pleasure, Eric.
Likewise. It's been
thanks so
great.
much for
Yeah,
coming in.
thank you both.
Appreciate it.
Appreciate it.